You ready? We got 1 minute to go. Now we got about 30 people on the screen. We attendees. Good evening, everybody. Welcome to our ICD webinar, bi-monthly webinar. And today we have our speaker, Professor Dr. Motiur Rahman Maula from Bangladesh. Let me introduce him today. Dr. Motiur Rahman is the professor of oral and maxillofacial surgery at the Anwar Khan Modern Medical College Hospital, Dhaka. He's also a senior consultant at the Evercare Hospital, Dhaka, an immediate past post of professor and founder or chairman, oral and maxillofacial surgery department and dean faculty of dentistry, Bangga Bamdu Sheikh Mujib Medical University, Dhaka. He is also president of Bangladesh Oral Cancer Society and Bangladesh Academy of Dentistry. He has a BDS from University of Dhaka and PhD from Hiroshima University on oncology. And thereon, he also got a FDS, a member of fellowship from Glasgow, and also fellowship from the Bangladesh College of Physicians and Surgeons. He also had a fellow of the FICD and FICS. His job included teaching experience for undergraduate and postgraduate students for more than 25 years, and has performed major oral and maxillofacial surgery since 1988. He has published over 55 publications in reputable international and international journals. Professor Dr. Motiur Rahman is also currently the region of Bangladesh. So tonight, our speaker, Professor Dr. Motiur Rahman, will talk about oral precancerous lesion, a clinical study on various pathology, and also a modified management protocol. Our webinar tonight is also available on YouTube as I post in the chat group. Without further ado, now I'd like to invite Professor Dr. Motiur Rahman to share his experience to talk about this topic tonight. Professor Motiur Rahman, it's all yours.
Thank you very much, Professor Ibrahim. And I'm also delighted that possibly Professor Hao Kim, the president of ICD Section 15, and our learned colleagues, the counselor, regent, representative of ICD Section 15. So good evening and assalamu alaikum from Bangladesh, Dhaka. As Professor Ibrahim was telling, I will be talking about a little bit about oral precancerous conditions or lesions, its clinical studies of various pathologies, and some modification of management protocol that I do follow in Bangladesh. So move on to my slide. Next one. So about just one slide about Bangladesh. You know, this is a small country with the huge population of 160 or 70 million people. But fortunately, we have improved the literacy rate in recent years. And as you could see, there are 83 recognized medical schools beside 15 dental schools. But the ratio of dentists and population is very low, as you can see. And we have much infant mortality rate, and life expectancy is 65. So initially I was, as Professor said, that I used to work in the University of Bangabandhu Sheikh Mujib Medical Institute at Dhaka University. In the department, I was chairman of the oral maxillofacial surgery and also dean faculty. And after that, after my retirement, I joined this Anwar Khan Modern Medical College few years ago, where I have a department of dental maxillofacial surgery, and we have at least 12 staffs, and also beside I am a senior consultant. Evercare is the only JCI accredited, is the top hospital in Dhaka city. Both the hospital has 250 beds for all patients. And so indoor patient that, just this is the record before I go to the main subject, that during this COVID period from 19 to March 2020 to 31 October 2021 is like 15 months, because we are closed for 4 months. Total case, surgical case was 96. And you can see from the data, more of the oral and head neck cancer and facial injury, fractures, benign tumors, cyst, surgical tooth extraction, and exploration, surgical exploration, alveolar bone graft for cleft cases, arthrocentesis for TMJ problem, and jaw corrective surgery. Although jaw corrective surgery is very common in Western countries, but in this country still is not very popular. Besides, we have a 3-month data for outpatient department where we have 4 dentists working with us, and we have our 3 maxillofacial surgeons with me. So our basic job is regular dental job like gum, periodontal disease, restorative work, endo. I don't do endo aesthetics, but they do. But this is my center, so I have just given it. So in 3 months, I have seen 500 patients. And among this, oral precancerous lesion, oral cancer is one of the major part of these patients. So this is what I do, also a little bit of dental implant. I'm happy to see Professor Howe, who has kindly be here. So thank you. And so this morning, when I was looking at my slides, this morning I saw 13 patients. Interestingly, I have classified here just today, this morning, 2 of them pre-malignant condition, 1 with the melanomatic pigmentation, 1 with hyperkeratosis, acanthosis, and dyskeratosis, that is the leukoplakia white patches. And the newly diagnosed today is 1 in the retromolar area, because they visited earlier. We did the biopsy and we got the biopsy report today. So SCC, and interestingly, all 3 patients were T4N1M0. You see, mostly retromolar area, buccal tissue, and cheek. So this is the common site in this country. And I have also 4 patients, post-surgical follow-up patient, 2 already admitted, and 2 came after 2-3 months. So that is again T4N2, because although the book suggests that T4B is not good to go for surgery, but in this country we often have to do advanced surgery with the T4 1 or TB with N2, N1, whatever, because that is the last resort they can afford, you see. And most of the government place, they have offered a free surgical treatment for the poor patient. And rather, radiotherapy, chemotherapy is expensive in this country, so we often go for surgery when possible. And of course, we have to go for a 3-dimensional clear excision by having some, frozen section biopsy that we try to do often for our case. And we have cyst, 1 cyst in the radicular cyst, TMJ arthralia, and impacted 3rd molar, and 1 implant case. So this was the case that I saw this morning. So you can see my practice nature. So I have 1 side with the general dentistry, 1 side with the maxillofacial side. So move on to the clinical case that this morning I saw. That is the pigmented melanomatic lesion. You can see here the dark pigmented spots right from the soft palate to the retromolar trigone and the buccal mucosa. So we did a biopsy 2 days ago, and the report came as if, of course, there is some melanotic material. So you have to have a very careful follow-up for this type of lesion. Although in Lichen Planus or Leukoplakia, we often have a long follow-up, but for this type of melanotic black spots or pigmentation, we have to be very careful because it may transform into malignancy all on a sudden, and you have to go for radical surgery. So I have asked the patient to come repeatedly, and if needed, we go for repeated biopsy to see if there is any changes. And next one that I saw this morning, you see the severe dysplastic changes. Not dysplastic, sorry. I would say the thick white, the plaque type of white lesion of the entire buccal mucosa. And we did and of course, the patient having habit of betel nut chewing and the pan and so on, it's tobacco. And I would mention like here that instead of smoking, our people are mostly habits of smokeless tobacco, like chewing tobacco. And that is the main culprit for having more white lesions and oral cancer in this country. So this patient also came with the burning mouth and difficulty in chewing food and all this. So we did the biopsy, histopathology, and interestingly, it has got acanthosis, squamous hyperplasia, and also some dyskaryotic changes also. So this is again a potent precancerous lesion where you need to go for early excision or other measure, just not the follow-up. So this is the two cases I presented. Just to bring the audience in a notification that what type of lesion that we deal every day almost. Now move on to the pre-malignant lesion. WHO and other authors have suggested pre-malignant lesions or conditions includes leukoplakia, erythroplakia, carcinoma situ, and precancerous condition Lichen Planus and submucous pruritus, besides few others pre-malignant condition. So we'll try to discuss about these things, especially leukoplakia, Lichen Planus, submucous oral fibrosis, and of course the precancerous, the carcinoma situ also. So. This is all know, but I thought that for a younger generation, I will just, not for professors, sorry, that we recapitulate the basic histology, that how epithelial layers, the keratin layers and the prickle cell layers and basement membrane and connective tissue, how the things are changing from mild dysplasia to moderate dysplasia, and ultimately severe dysplasia and carcinoma situ. So these all know, but I thought that we'll put one. So about the global incidence, risk factors that we have in India, Bangladesh, Sri Lanka, Pakistan, and many other countries. This slide I used also in the last lecture also, that interestingly, in the Western countries, the habits is definitely different. They are more prone to have, the alcohol and others. So because of the possibility, the chewing habit and all these, and the food adulteration, radiation, pollution, all this, we have a lot of oral head neck cancers, throat cancer, lung cancer, and so on. And interestingly, in Europe, you can see, or America, you can see mostly is like only 5 to 8%, whereas in our cases, it is like 25 to 30% in Southeast Asia. So there are some few references there, and you all know this. I wanted to remind all of us that we are in a situation where it is really a tremendous problem of precancerous lesion and the cancer. So that is how, if you see the globe, the red mark is the affected area. And so, so we know the Asia, Africa, and part of Latin America, the most prone area where this population are suffering from, the precancerous condition and the oral cancer or head neck cancer. Like one of the data from by Shalini Gupta, Rajendra Singh, they are showing clearly that from one of the study of 311 cases, oral submucous fibrosis is out of them, interestingly, very high, 71%, to 22. Oral cancer is 59. Lichen Planus is very less, that is 2.3%, and Leukoplakia is 23. Our condition is a little different, so I will discuss later. So, and the food habits or the habits are tobacco, pan masala, mixed with tobacco chewing, and things like that. These are again, quite common in the subcontinent, you see. Maybe it's not common in Malaysia, but it is common in Pakistan, India, Bangladesh, Sri Lanka, I think. So we have similar type of pathologies, precancerous lesions and all. One of the study shows from Bangladesh, which was published in Journal of Medical Science Research in 2012, is old, although from Bangladeshi, our doctor, it's clearly shown again, the betel quid chewing is 51%, smoking is 10%, and both is something like that. So conventional histological grading, that is, you can again see stage 3 and 4 is the higher number, that is 31 and 55%, and the mean age is 53.48%. So this also indicates quite similar to Indian presentation, you see. And recently, there is again interesting, that is the human papillomavirus, HPV, which was basically initially was thought to be causing cervix cancer for the female, but these days is also being found to be oral cancer, especially the tongue cancer, throat cancer. Is quite, the association of the HPV virus. So that I thought that this should be also a slide today. So, sorry, so move on to my today's topics, that is on oral leukoplakia. So leukoplakia, as you know, the white plaque and of different types, and it could be mostly involved. In our case, we see mostly in the buccal mucosa, palate, tongue, lip, and so on. You see, and more. These are more affected. Smokers are more affected, 6 times more affected than the non-smokers. Basically, 2 types: is the homogeneous and non-homogeneous. Or homogeneous is the flat, thin patches and shallow cracks are there. But non-homogeneous is often combined with white and red lesions, similar to erythroplakia, nodular, granular, verrucous. There are various types. These are the rather more potent lesion which can really transform into malignancy. So histologically, there is basically, we would say, although there is a lot of histological variation, but we'll grossly divide into dysplastic and non-dysplastic. As you know, dysplastic means towards the carcinoma. So these are few patients sampled from our clinic, that how various types of leukoplakia of various types, verrucous, plaque, or dysplastic severe type is coming to us with the various places like retromalaria, both the buccal mucosa, tongue, and so on, palate, and so on. And also some, if you go look carefully, like say peripheral verrucous type, nodular type, granular type. So these are and as we discussed, the basic idea about the leukoplakia, as you know, we all know about the epithelial layer. So if you think from the top, that is the keratin layer, that is initially when there is irritation by the chewing betel nut or alcohol, anything, the changes initially comes to the top surface, that is the hyperkeratosis, orthokeratosis, that is thick layer of this, and then gradually the changes of the prickle cell layer, that is the polyhedral, the squamous cell, there is some acanthosis, and then squamous metaplasia, and ultimately there will be some, the dysplastic changes, mild to moderate, and ultimately this is one of the cases that we sent for biopsy here, And the report was, although this is an early stage of, the Leukoplakia, there is not much neoplastic changes or dysplastic changes. So this is one of the cases I just showed here. And of course, they have betel nut chewing and the tobacco chewing. Another case having no true, also, although there is a keratinization, but no true dysplastic changes. So we're happy about it. In this condition, we try to have a follow-up, regular follow-up. That we'll discuss how we do follow-up and treatment protocol later. And there is one malignant transformation. This can just 1 minute. Can you move this one? Sorry. No, it is okay. No, sorry. So malignant transformation is one of the patient data from the long-term treatment outcome of oral pre-malignant lesions that was published in Oral Oncology 2006, May 26, and this is the reference is there. So there, out of 269 patients, is an Indian study. There's two groups. One, they have just follow-up without doing surgery. Another, they did, say, excision, like 94 cases. Interestingly, in surgical case, 12% develop cancer, and that is among the non-homogeneous is more, that is 20%. So as I told you, non-homogeneous type of, the Leukoplakia is more potent to transform into malignancy. So interestingly, on the other side also, non-homogeneous type is also having more chances of development. So Leukoplakia transforming to carcinoma, mainly involving the tongue. So that this is also these are the all photographs from my clinic. So various forms and sites of the, sometimes it is fissure, sometimes it is also candidiasis, sometimes you can say that the fissured or depapillation or induration with the cauliflower-like changes, or sometimes even up to the carcinoma, invasive carcinosis. So these are the various steps that patient is coming. So in my chamber, I said, every day I normally see in the full, says 4 hours, 5 hours, time, then normally I see 15, 20 patients. Out of them, at least 20% or 25% cases are either precancerous lesion or some of them are cancer. So this is one of the patients from our hospital we sent for stable pathology. One thing I must notify here, in Bangladesh, we have a lot of difficulty having good oral pathological analysis, you see, because we have only 1 or 2 oral pathologists in the whole country, which is very much lacking. So we depend on general pathologists, and sometimes we have difficulty understanding, not for these precancerous lesion, but also for other various maxillofacial pathologies. It's very difficult to understand their analysis and the diagnosis. So this is how in carcinoma situ, as you all know, that if there is a dysplastic changes, how that changes from the epithelium, ultimately proceeding towards the basal layer, and is almost in the stage of invading the basal layer to go to the connective tissue. See, so that is the dysplastic changes. So that's what I try to show you here. So you have to be very careful, understand, and do time to time biopsy to prevent this stage so that you can solve the patient before it turns to invasive carcinoma. So Leukoplakia, for Leukoplakia, the risk factors are females are more potent, and long duration, of course, non-smokers having, if the non-smoker having the Leukoplakia, they are more prone to develop malignancy. And I told you, non-homogeneous type. And some authors also say that the presence of Candida albicans may be an additional factors which can cause transformation of malignancy. So these are the things one may keep in mind. So when you have a patient, if you diagnose initially, have a regular follow-up, and try to see these points if this fits with you. So I'm talking now about the basic, say for example, basic pathology or clinical feature of leukoplakia. Now moving on to the erythroplakia, another very potent precancerous condition. And many of us, you know, that once this diagnosis, you know, it is a red velvety color and thin layered, lesions, mostly in the soft tissue, that mucosa, palate, lip, and things like that. And once it diagnoses, mostly majority of the cases are already in the stage of carcinoma situ. So that is why you have to be very careful looking at the red lesions, especially. So these are the findings and the clinical features that I normally try to bring it here so that one can understand. But so important is that it is a disease or condition where majority, like up to 40% may be in the stage of malignancy, precancerous condition, malignancy, either is in carcinoma situ or already in the early stage of invasive carcinoma. So little bit about the oral lichen planus, although it is an autoimmune inflammatory disease, is not unlike the other two diseases, it is different. So that is why it is the concept of this lichen planus is different, you see. So you have to assure the patient, make the patient understand about the pathogenesis and the causes, and ultimately, best thing is that you have to have a regular follow-up of the patient. Usually, lichen planus is usually you can see on the both sides of the mucosa, striation there, the thinning is there, some atrophy is there. So there is a lot of variation that we can see, and like the papular and reticular type, plaque type, atrophic and erosive. Erosive type is more potent to develop sometime dysplastic changes. So we have to be very careful about this. So we know, if you know the histopathology, and especially the retipeg, you see is saw-like, and there will be some the chronic inflammatory cells and things like that. It is very, very easy to understand the, especially you have to be very careful of erosive type, and sometimes is bullous lesion also. So these are all is noticed, notified in the textbook. Lichen planus, from this is also pictures from our clinic. Like this is the striation is there, and sometimes there is also restoration, amalgam restoration induced leukoplakia, lichen planus, or the erosive type lichen planus. These are the condition where you have to be very carefully see. So this is one of the patient, only with the age of 29 years old male, biopsy taken from the buccal mucosa, and although both sides clinically leukoplakia, but histologically they said it is a case of lichen planus because of the possibly the main thing that they saw is the retipeg in the saw-shaped and the lymphocyte infiltration. Now, this is the main thing that I am going to today discuss about this, and my study is on today. Clinical study is on oral submucous fiber that I have discussed details, the methodology and the treatment protocol and ultimate result that I will discuss later. So about the oral submucous fibrosis, as you know, this is again something. The epithelium is being fibrosed, atrophied, lack of blood supply, and also granulation tissue. The collagen fibers are there, and is being replaced by the hyaline tissue. So these are and the patient comes with burning mouth, tightness of the mouth, and trismus, even to severe trismus like only one finger or even no opening. So these are the typical condition. If you look at the oral cavity, you can see the pale white soft palate, a buccal mucosa. You can see also the bend in the buccal side or the retromolar area, where thereby the patient can open the mouth. See, and this is another, I mean, the pathogenesis one has said, like with the, if you are having brittle quid or some alcohol or something, constant irritation, chronic inflammation, activation of T cell macrophages, and ultimately this is how it activates to form into, I mean, they transform into oral submucous fibrosis. And the staging, this is also being noticed in the written definitely in the various textbook or journal. Clinical staging, we can stage by the bands, you see, and the functional staging by seeing the trismus or mouth opening. If it is more than 120, there is stage 1 and 2 and 3. So these are just for your notification. I have, and the submucosal fibrosis, early, moderate, advanced, and we have, and if you classify in basic histological staging, in epithelium, very early stage, early, moderate, advanced stage, and epithelium, mild hyperkeratosis, early stage keratosis, orthokeratosis, and advanced case orthokeratosis, and both parakeratosis. But dysplasia, in case of dysplasia, in case of mild and very early and early, no dysplasia, moderate stage 3, you can see few dysplastic changes, and in advanced cases, moderate dysplastic changes can be seen. And that is the basic histological staging. One has, many authors has classified like this: very early, moderate, advanced. By seeing the, I mean, the collagen disperse, how it is dispersed in the, I mean, the tissue with the edema, and juxtaepithelial hyalinization. And in case of moderate, this collagen moderately hyalinized. As you can, it is being all written here. And there's also another group of fibroblast response strong, and fibroblast marked in case of moderate, less marked, mostly adult lymphocyte, and devoid of fibroblast in case of advanced cases. That is the striking point. That is the devoid of fibroblast in advanced cases. Blood vessel being ultimately congested and constricted and completely obliterated in case of advanced stage of oral submucous fibrosis. And inflammatory cells are especially, again, lymphocyte plasma cells are more seen in the advanced and moderate stage. And these are the one hypothesis that how I mean, the oral submucous fibrosis transform into malignancy. I will not go through this, but I just put one, how the fibrosis starts and the reduce of blood supply, blood in oxygen, poor oxygen supply, hypoxia, cell death, and necrosis. So these are the basically hypothesis and theory. Ultimately, production of inflammatory cytokine, recruit tumor promoting macrophages, form it. So ultimately, finally, that is the malignant transformation may happen. Not all, but some cases it may happen. So this is little bit the basic idea that I discussed about leukoplakia, erythroplakia, lichen planus, and oral submucous fibrosis. Now, my little different philosophy of management, you see, because I have been seeing so many patients of precancerous lesion for many years. So I have guided, I have made a protocol, you see, guided protocol in our chamber, our center, that whatever the patient comes with the, oral ulcer, precancerous condition, or cancer, we must first of all maintain the oral hygiene. That is, the gum management and the tooth management, everything should be done. Brushing technique should be improved. That is very, very important. And cessation of all bad habits. And most of the patient comes with the tobacco chewing or the smoking or poor oral hygiene or betel nut chewing and things like that, or snuffs. So these are the common things that we can see here. So we try to counsel the patient, try to motivate the patient, motivate the patient to avoid this. Initially, some people reluctant to, give up these habits because it is an addiction, because of tobacco. So that is important, that how we have to do it, that we try to make them understand, counsel them. And then initially we usually give some antifungal drop, like nystatin, because majority of the cases have superadded with the fungal infection. So before we go for, so we clear this usual fungal. And then sometime, depending on the cases times, we use topical steroid, triamcinolone or other steroid, you can use it. And supplement therapy like beta carotene, vitamin C, B, zinc, and iron, and things, depending on how the patients are having deficiency or things like that. And then the patients having regular visit for up to at least this study, as we did 2.5 years to 3 years. And the specific treatment that we follow, that when you have to follow up, when you suspect, especially if it is for a long time and is not improving with the common management, then we tend to go for biopsy. And histology suspicious case when there is, the much chaser dysplasia or things like that, then we tend to say that we have to go for some aggressive like excision or laser therapy or something like that, But normally what I am trying to say today, especially for oral submucous fibrosis and recurrent leukoplakia, I prefer very much intralesional injection beside the common control of the oral hygiene, deficiency correction, and cessation of the bad habit. This is what I'm trying to say today. And I'm using regularly, especially for the aggressive lesions, that is the injection combined with triamcinolone or dexamethasone mixed with placental extracts, hyaluronidase, twice or weekly into the lesion. So especially band area or buccal mucous area. And I will come to you later the effect of this. And of course, you need to do for some time, it is not helpful if there is severe band and the patient is unable to open the mouth. You have to help the patient by taking excise the band and do some flap reconstruction. And commonly what I do is the fat graft, fat graft and the nasolabial flap. This is the two common things that I do, simple but very effective after removing the severe band in case of submucous fibrosis that I normally do here. And chemo prevention I just mentioned here because this is a general talk, so I just mentioned here. So sometimes we have to use some systemic steroid also when there is a stubborn type of leukoplakia or even lichen planus and is not helping. So depending on the cases, you also sometimes go for oral intervention of the steroid. So these are how the dexamethasone or the other steroids usually helps in reduction of the inflammation, prevent the fibrosis, decreasing fibroblast and things like the collagen. And hyaluronidase is also very helpful is it improves the intercellular cement substance. They have a decreased trismus, and it also helps in the reducing the trismus. And placenta extract is a repair thing, you see. That is why the ladies are using in the face for the facial repair, or the what you call it, age marks, you see. So this is an example how we have two devices, that is the CO2 laser and diode laser. We sometimes, not all cases, we use sometime. And now move on to my study, that from June 2014 to June 2019, the incidence of precancerous and carcinoma, total number of precancer patients in 5 years is 2,984. And out of that, besides the carcinoma, 624. And most of them are in the stage 3 and 4. See. So leukoplakia is something like, leukoplakia 964 of various types, and submucous fibers is also very high, 476. Forget it, keep it. Erythroplakia is something like 384, and so on, you see. And so squamous cell carcinoma is also very high in 624. And in case of, in 5 years time, that in 2014 to June 2019. So this is one of the studies that I am going to discuss today. So that same study, so what we have done is the adjusted comparative study, you see. So this is my study result compared and adjusted with the other results of like Guruken, Elisa, Gupta, Mehta, and Cox and Carville. That's listed in the bottom of the studies compared with those studies. And I have seen that complete remission could be gained in 12 to 32%. These are the results of my studies with the other 5 results or the studies, you see. So that is why I've just listed as from from 12 to 32%. Partial remission, 50 to 85%. And malignant transformation is 12 to 14%. Erythroplakia is very high, is up to, malignant transformation is even up to 55%. And submucous wall fibrosis, interestingly, partial remission is there, around 16 to 55%, but recurrence rate after 74%, if there is, especially if there is no good follow-up, the patient will come back with the same, the burning mouth and trismus and so on. And Lichen Planus is also similar. It's a very difficult case that you have to have long follow-up and counsel the patient. So this is a result of my studies compared, adjusted with other 5 authors. See, and now I'm talking about my results using, say, 476 oral submucous fibrosis, and that is the same duration, that is the 5 years for 2014 to 2019. And treatment I have given among the general management, as you know, oral hygiene, correctional deficiency, topical application steroid, mouth opening exercise for the rest of the patient, and that I do for all patients. And at the same time, I did interlesional triple injection. Triple injection means that is the combination of those triamcinolone and then the hyaluronidase and the Placentrix. These 3 things I will give you details later. So that is mixed in a insulin 1 cc, I have a small needle syringe, then inject slowly. And before that, we use the anesthetic gel in the mucosa, and that is not very difficult. Patient can accommodate this little pain. So this is what I like to advocate. I will discuss later. And I did some excision of the band because of the severe difficulty of the mouth, and to give more opening. So I did the fat graft and also pedicle fat graft, of course, and nasolabial flap reconstruction in 56 cases. And that is the thing that I did method in 5 years case in last, between 14 to 29 years. So these are the few cases, severe cases that I can see. If I've just at random, I put it here in this slide here, you see. And this is the reminder, as we knew that this is then textbook classification of early, very early, moderate, and advanced, So this we know. So, and the clinical staging that from our study, my study, that is 476 cases. Total number is the case, for instance, the common sites is the buccal mucosa, lip, and soft palate, and sometimes entire oropharynx. You see, patient having difficulty in swallowing food, of course, with the burning mouth. Age range is 27 to 60 years. And the early stage we have classified in 3, unlike the other 4. I have classified early stage 1 and 2, and trismus is something, is like 25 millimeter or more, and the moderate stage 3 is like 10 to 20 millimeters, you see, of interincisal mouth opening. And then advanced stage is very, very less, almost nil, like 2 to 9 millimeter. Histological grading, stage 1 and 2 is 36%, and the moderate stage 3, 30%, and advanced stage, that is with the dysplastic changes, in 34%. It's a very high number, and this is one of the, the slide of 46 years old female patient suffering from burning mouth, trismus, and thick buccal band. So tissue was biopsied, and the most of the tissue you can see from the others, and the fibrous tissue was replaced by hyalinized tissue. See, so that is the tremendous changes in advanced cases. And if you look carefully, there will be some also dysplastic changes also. This is one of the cases I would like to, clinical case that I will show. There is one case, his name is 46 years old female, from Chittagong, Bangladesh, betel nut chewing and chewing habit, preoperative clinical trismus, burning mouth in the oropharynx, and pale fibrotic. If you feel with the finger, it's very hard. There is no softness of the, the buccal mucosa or cheek. It involved up to the soft palate and oropharynx. And there is a retromolar band, see, on both the side. So it is a clear, singly visible and understandable picture of any severe submucous oral fibrosis. And so what we did the maintenance, oral height maintenance. We did retinol, vitamin B, zinc, and all these, and also started with the topical application of steroid. And normally I ask the patient to apply steroid like the Kenalog or things like that at the bedtime and the night. And specifically intradistal triple injection, that includes dexamethasone, 5 milligram per ml, injection Placentrex, 0.1 gram per ml, and injection hyaluronidase, 1500 international unit. So this is the combination that I commonly use, mixed all 3, and try to inject slowly twice a week, at least for, depending on the cases, 10 to 15, 16 cases, 16 times only. For this case also we did 16 times, I think, yeah. And so ultimately there is no burning mouth, slight improvement of the mouth opening, and slightly the buccal mucosa becomes softer, and color also changes to pink. Another patient, this is a clinical severe patient, severe cases, 50 years age from Sylhet. They are having again the betel nut chewing and the red chili. They used to take a lot of spices in their daily meal. Also, the patient having trismus, burning mouth, and the pale fibrotic and things like that. And traumatic ulceration on the molar side because of the tight, buccal tissue. And there was sharp tooth, so there was some traumatic ulcer on the both buccal side, you see. So it is also a case of severe oral submucous fibrosis. And so similar thing we did, mainly the triple injection, that is the combination of all three drugs. So outcome ultimately after, of course, many months, that is improvement of the mouth opening and color of the color also changed to nearly pink. Another case, interesting case of submucous fibrosis. Initially we were having follow-up and the biopsy never showed any dysplastic changes or severe changes. But in course of time, after a few months, the patient transformed into malignancy with dysplastic changes. So that is why you have to have, I'm sorry that you cannot see clearly about, these are the histopathology reports, one from, one from India, one from Bangladesh. So from the last one is clearly shown that there is some dysplastic change. So it is being transformed from dysplastic change to carcinoma C2. And the surgical management of severe buccal band, as I told you, I follow the buccal fat of graft. Easy, very easy. I will show you the example. And also the nasolabial flap is also very easy for the reconstruction after the excision, because you cannot close locally because of devoid of blood supply. The tissue is very hard. You cannot close the local defect. So you must need definitely a pedicle flap, you see, with the blood supply intact. So this is an example how we do easily. So this is a lesion in the buccal area. You remove the lesion and you give an incision at below the submandibular ductal opening, parotid ductal opening, and then give an incision, horizontal incision, reach the buccal muscle, and you can easily pop the nice little, the fat, you see, that you bring slowly and bring into the position and tie it. And in addition, we also can use the collagen membrane that you normally use in case of, say, for example, a gum flap surgery, or even in case of implant surgery. So same, the collagen can also be put over the fat graft. Or very easily, we can go for, as a surgeon, it's very, we say like this, that you can go for nasolabial, superior base nasolabial pedicle grafts that we can easily use it. Of course, we have to do it under general anesthesia, keeping the blood supply intact, facial blood supply intact, and rotate inside the band where you have excite, and ultimately there will be good healing and good mouth opening. So these are the examples. And the outcome of my the cases that I have, especially submucosal fibrosis in these 5 years. So I would grossly say that complete remission is very difficult, because complete remission is only around 10 to 11%. That is, complete remission means no burning mouth, good opening, mouth opening. And partial remission, I have classified like, mostly there is no burning mouth, but mouth opening is little reduced, 20 to 25 millimeter. But recurrence, as you know, after 36 months, the patient came back with some burning mouth, trismus from the improvement. Say we have follow up for 1 year or 2 years, then patient usually go away. And after that, they come back after 2.5 years or 3 years. Then again, there is some, burning mouth, some restriction of mouth, but not to the primary stage. But so there is a recurrence of the lesion, the recurrence of the symptoms, and the condition. And 16, in my case, 16%, 16% quite high, I would say, has transformed into malignancy. Most of them are carcinocytic, and some fewer of them in the invasive carcinoma. So from this study, small study, what we could say, the detailed clinical information, repeated histological and clinical evaluation after the management outcome of minimum 5 years or more is on the way for next publication. We have done an initial and study of, this number of patients of various pathology. Especially, I would like to mention about the squamous, oral submucous fibrosis. But we need to have a precise, thorough, repeated biopsy to see the changes of the tissues or cells when you do the, either you do the, you apply the steroid or international injection, but you have to see really repeatedly histological change, which is sometimes very difficult in this country because, the poverty, lack of transportation, and many problems there, lack of facilities. So that is an environmental, difficulty, and medical facilities lack. So that will be always a hindrance for this, our country. So we always invite that our friends from Malaysia or any advanced country or Singapore, Hong Kong, India, Pakistan, whoever can, we should come forward to help each other, collaborate, and to see how we can help for the poor community patients. So little bit about the early detection of precancellation and oral cancer that we follow here. And as you know, this is very easy. It's just simply what we do in our daily life, not daily life. We have a society called Bangladesh Oral Cancer Society, and dental society is there. We often go to the rural area for free dental camp, where you also go for free, early detection of precancers or lesion, by using your veloscope or local simple iodine. Local iodine is very simple. You rinse with the patient mouth, and then rinse with the, or even the toluidine blue is also very easy to use it, and then rinse with weak acetic acid. And after that, you check inside the mouth with light. And if there is a prone area, then you take patient biopsy, and those tissue is brought to the center, to understand the pathology or dysplastic changes or something, or already in stage of invasive carcinoma. And then you bring the patient to the center for the treatment. So this is what is very important, and we should keep in mind. And this is the thing that we do in Bangladesh, and this is being published in South Asian Journal, Cancer 2013, although very old. But I thought, so again, we do that community support, educational, warning signals, news media, paper media, and things like the tobacco control. Although we say that we should not smoke, we should avoid taking and chewing tobacco. On the other hand, government is taking, the good tax for the production of the smokes, cigarettes. That is a controversial issue. This is the problem in the poor developing countries because of the poverty. Government has to depend on the many things. So that is why to control the tobacco is very, very difficult in this country, like India and maybe also Pakistan and many other countries. So these are the things that we have to keep in mind. So this is one of the society, that is Bangladesh Oral Cancer Society. The regular practice that we do some press conference, and also you go to rural area, bring the leaders of the rural community to make them understand, give some leaflets. And this is one of the scenario of a simple single dental free dental camp with the screening egg. So you can see the simple device. You just looking at your mouth with the light and mirror, and you see the queue of the patient waiting for. And in one day, you can see we have treated 25 cleft patient and 500 extraction and 225 cancer screening. Like বন্ধ হয়েছে নিচে দেখো দেখো তো ভালো করে দেখো so this is how the life in Bangladesh is. If you come, really we like to invite all our ICT friends and other friends to visit Bangladesh or go with us to the rural area. We'll see the scenario is different. It's unlike in many developed country like Malaysia or the Singapore, Hong Kong. It is different. It's different. And I remember our beloved, the president, Professor Howe, was with us in 2019 in the this is the big gathering conference, like 1,500 dental surgeons gathered together for the 2-day conference that happened also last in 2019. He was kind enough to come and help us and encourage us. So thank you once again, the Professor Howe, for the friendship. So we also organize the Oral Cancer Society every year, but because of COVID, we could not organize regularly. But this was the last 2017 we organized. We invite many foreign the speakers from Sri Lanka, England, India, Japan, and we have because of the pre-cancer and cancer is one of the main issue of dental problem in this country. So that is why you focused on oral cancer, pre-cancer cancer, and so on. Take-home message is precancerous lesion, including leukoplakia, especially the non-homogeneous verrucous plaque type, oral submucous fibrosis, leukoplakia are the potent lesion, easily shows severe dysplasia, ultimately to carcinosis. So we have to be very careful, and you have to, if you have a sharp clinical eye, we understand homogeneous, non-homogeneous type, and the verrucous type and erosive type of the both leukoplakia, lichen planus, and also the advanced stage of the submucous oral fibrosis, that you can, with your experience, if you see the patient lot many, then you have easy understanding, clinical experience. But ultimately, you have to go for time-to-time biopsy and understand the possible condition and possibly prevent from the transform the patient towards the malignancy. And precancerous condition, including lichen planus, needs regular visit for oral hygiene, medication, interditional injection. Sometimes it can be, I have limited experience about CO2 laser, but I have more experience with the interditional injection, that I must say, and I've been using regularly. Many of the authors internationally will say that these injections may not be helpful for submucous fibrosis, but I like to clearly say that it can definitely control the symptom, like the burning mouth. It can definitely change the hardness of the mucosa, increase definitely to some extent the fibrosis, the mouth opening trismus, and if definitely it can prevent, possibly largely, towards from the transformation of the carcinoma. I'm not telling you that this method will completely cure the submucous fibrosis, but it definitely is helpful for these patients. And oral cancer, head neck cancer in this country mostly comes in a very advanced stage and is a disaster and tremendous problem in this country. And in my practice where I do say 2-day surgery, and mostly are cancer patients. And I have to do all stage 4, mostly stage 4, where you need to resection of the jaw, reconstruction, and neck dissection, and reconstruction. I don't do microvascular surgery. I bring the plastic surgery friend with me for the microvascular surgery. But I do excision and simple reconstruction and pedicle grafts, like temporalis graft or the temporalis graft or submental island flap graft or things like that. These are quite convenient and can be very useful for this moderate defect of the oral cavity. So this is another thing that I want to say. And most patients come in advanced stage, so because of the lack of awareness, mainly in the rural area. So I think that's my team. I am working at the moment at Anwar Khan Modern Medical College Hospital. It is a 250-bed hospital, and that is an other hospital that is the JCI accredited Evercare Hospital, the only top hospital in Bangladesh. It is something like 260 bed for the all the major subjects, and I took help of the histology from Professor Ghulam Mustafa and Professor S.I. Khan, because as I told you, we have only one oral pathologist in the whole country, and we have a lot of difficulty understanding many other oral pathological conditions or the maxillofacial pathologies. So that is a sad part, and thank you, learned audience. I'd like to acknowledge Professor Hao Kim Chuan, our beloved president of ICT Section 15, Professor Dr. Muhammad Ibrahim, who has actually invited me for this session, and of course all the counselors and the regents and fellow friends from all the countries of Section 15. Thank you very much once again for your patience hearing. Thank you.
Thank you very much, Professor Motiur Rahman, for the very interesting and very informative lectures for our audience tonight. And for your information, we got close about 100 viewers, about 70 from the Zoom and about 20 over from our YouTube channel. Is for your information, so statistics-wise. And also, I'd like to acknowledge the presence of our president, Dr. Hakim Chuan, and also our Deputy President, Professor Ashad Malik, with us tonight. Professor Malik. So I think from the, I don't know, before I go on, if our President wants to say anything to our speaker today's evening, Dato'?
Yes, thank you very much, Dr. Prof. Muhammad Ibrahim, as well as Prof. Motiur Rahman Mora. Right, thank you. This is excellent presentation, and it really helped me to remind me of all those that I studied my FDS as well as my undergraduate. Right, Prof. I have a few questions to ask. If you don't mind, I start the ball rolling. All right. The first is that, right, among the pre-cancellous lesion, you mentioned about that you can use placenta extract, you can use hyaluronidase, you also use triamcinolone, laser plus chemotherapy. Which will be your first line of treatment in the pre-cancellous lesion?
Okay, sir. I will say that for all precancerous condition or lesions, I would go for severe, control of the oral hygiene maintenance.
Oral hygiene maintenance.
And also, I will not take the patient who are not, ceasing the bad habits. So cessation of the bad habits, and then I will initially start with mostly with the topical application of the steroid, along with the correction. But I prefer the interlesional triple injection, and
right.
Few cases because of the severe band where you cannot help it but for excision.
All right. So you mentioned about oral hygiene, which I truly agree with you. Do you also think that the pre-cancellous lesion has got to do with the oral microorganism, like for example, the interaction between oral bacteria, virus, and fungus? And so does that play a role in the malignant change as well as the pre-cancellous lesion?
Yes, as I told in my lecture initially, there's one slide, that most of the patient has superadded fungal infection. Candida albicans is one of them. And I have seen those are involved with the Candida, they are having more difficulty in treating those patients. So there must be some correlation with these lesions. So I tend to control the fungal infection first and then go for the other specific treatment for the lesion specific.
Right, thank you. I am very interested in two of your treatment modality. Number one is actually the laser treatment. Number two is the placenta extract. Would you like to elaborate a little bit more on these two treatment modality?
Placenta extract. Placenta extract. So first of all, he said,
it's a laser therapy like CO2. The other one is a placenta extract.
Okay, so laser therapy, I mostly use CO2 laser, and with various watts you see from right from 3, 4, 5 watts, depending on the thickness or the stubbornness of the lesion. You see, laser CO2 laser normally I use in some cases where I have tried with the topical steroid, you see, and is not helping. The verrucous type, plaque type, or something which is really not changing. So what then I said that we'll go for laser, CO2 laser ablation, and if it is a whole oral mucosa, then we tend to do half-wise. See, one day another part of the lesion, and then I repeat after 2 weeks after seeing the observation, observe how it's changing. Then we go for 2 weeks. After 2 weeks, I repeat. Normally, I said I will apply 2 to 4 times of laser to stubborn lesions. And in case of submucous fibrosis, the laser therapy. Rather, in case of other
Are you okay, Professor Motiur Rahman?
I think the line. Professor, I think you're muted. Do you mind to unmute yourself? Yes. Thank you.
We can hear you, Motiur Rahman. You can speak a bit louder. You're muted, Professor Rahman.
Professor, you're muted now, Professor. Do you mind to unmute yourself?
No, okay.
Yes, we can hear you right now.
So for laser, sorry, I'm a subjective problem. For laser, so that's I'm not using in all cases. In certain cases where I think that your dental treatment of these, management of oral hygiene, then the topical application and the retinol and all these things are not very useful. Can you hear me?
Yes, can hear you.
Okay.
All right. Thank you.
And
Thank
then,
you very much. Yeah.
And then only I tried to go for this. And then so my experience is that I am saying that I am not using this laser in all cases, only limited cases, and I get most of the cases, the result is reasonably good, I would say, although I cannot say histologically how they have improved, but I think this is very helpful.
Thank you.
So
Thank you.
Anything else?
Yeah,
if you have experience,
I have no further questions.
I think you have better experience about you have better experience about laser, you can add me at.
Okay, thank you for the question. Now, there is two questions on the
The
chat.
last question was.
Now, one was answered.
One more question about
Malik. One question was answered by Professor Malik about the amalgam. Yeah. Do you want to add anything to what Professor Malik has answered our participant, Professor Motiur Rahman?
I didn't see. I didn't see any answer.
The question was mercury. I mean, the question was amalgam responsible for the lichen planus, and Professor Ashad Malik responded due to the mercury. You want to add anything else, or Professor Ashad Malik want to speak something?
Yeah, please let him say. Professor Ashad Malik, thank you for joining here. If you have anything else that you can add for this issue,
thank you very much, especially my regards to my president, and especially very much my rather very efficient and very hardworking our chairman scientific committee, that he has make us proud that we all are sitting here. Motiur Mola, your topic is so excellent that you have presented every damn thing of the submucous fibrosis, right, starting from the histopathology, right, from the other variations, and then coming to its varieties and then classifications. Although there are few classifications in 2021, they are now introduced according to the pillars. So then what you said that regarding to the laser therapy, there's a two types of the laser therapy which we are favoring in submucous fibrosis. One is that is the ablasive one, and that what you are doing very excellently, that is carbon dioxide laser. Some people do it in striation, say that they are taking lights from the pillar from the vestibule and going up to the tonsillar pillars, and they make one cut, second cut of the upper level of the buccal vestibule, and third cut at the low level of the vestibule. They make 3 lines of the carbon dioxide laser striation, and then they ask the patient to, they open the patient in general anesthesia. Then you have 3 spots, defect spots, and in these 3 defect spots, we used to place what you said, the collagen strips. And we, rather than getting any nasolabial flap or temporal muscle flap, we take these 3 strips of the collagen fibers and we stitch it right there. The collagen same which we use in periodontology, or sometimes we give it the artificial bone covering in implantology. And these long strips we stitch is there, and these gaps they maintain there. We place the mouth probe in the mouth for approximately 4 days, and these collagen give a very good epithelialization and the area. And this study, actually, I was not aware of that. Otherwise, I could have shown you this study. This is 2-3 studies they are done in our centers, and they are very successful. This is the one way of carbon dioxide laser given. And second, what you are doing, that is very ablasive one, and that is you just evaporate it, or just you take the cut and taking the nasolabial flap and putting in the defect. That is what is the routine, and that is a very safe one as well. Secondly, Dr. Ho will second me that we are also trying for the soft laser as well, that we used to apply certain joules, sometimes 3 joules, sometimes 5 joules on the buccal mucosa inside, and we give a regular therapy for 1 week or 2 weeks, and we have seen that there is a fibrolytic activity is there, it is introduced, and especially helium neon and diode laser. These 2 lasers, they give very promising results, especially in submucous fibrosis. These are the 2 things which we are doing in laser therapy for the submucous fibrosis. But the excellent presentation, Motiur Mola, I don't think that one can have such an excellent presentation more than this what the Motiur Mola you have presented. It's a very excellent one, and I'm very much thankful to especially Datu Ibrahim that he used to bring so excellent speakers to us, and it is really very promising one. Thank you.
And can I add one thing here? What I was trying to say that I'm not using this, excision band and the nasolabial fold, nasolabial flap, or the fat graft only in severe cases where there is devoid of blood supply, severe tissue fibrosis. So it is difficult to bring any, non-pedicle flap, you see, because we have tried with other mucosal graft or the skin graft, which has failed. So that is why I limit this surgery only in these advanced severe cases of severe wound. That like to add it.
That Motiur, excellent one. Dr. Motiur, may I ask you that ever you tried a tongue flap, a lateral tongue flap? Yes. Because one of our very good friend, you well know that Dr. This Riyaz Varaj, he has given 2 cases of tongue flap, and he said that because the lateral border has the good vascular supply, so it may retain. Have you any experience of the lateral border flap?
Yes, I have a lot of experience using this lateral tongue flap, especially not for this, but for other cases with the defect of the buccal mucosa, or even for the palatal defect, you see, after the cleft surgery or nasolabial, oronasal fistula, you see. So we have, I have a lot of experience with the mid tongue, mid dorsal, and also the lateral side of the tongue. I have experience. Only thing is that patient is a little uncomfortable because the 2 weeks you have to keep the patient tongue tight. The patient is little feeling discomfort. That's the thing that I know.
Okay, thank you, Professor Motiur Rahman. Before I ask another question on the chat, I should acknowledge your deputy regent, Dr. Shakawat, also with us tonight. And the next question from our audience tonight is from Dr. Rosman Mujianto. He asked, why use antihistamine for OLP treatment? You get the question?
Antihistamine, right?
Antihistamine for OLP treatment.
Antihistamine is not a specific treatment for this, you see. It is an hypothetical consideration. While you were giving, antifungal drug like super infection, and because of the nature of the lesion in case of Lichen Planus, I just thought that I will put some, 7 or 10 days of antihistamine. That's not a major issue for my treatment protocols. Thank you.
Okay, thank you very much. Okay, I think we have come almost about 10 minutes to 11 tonight in Malaysian time. So on behalf of section 15, we'd like to thank you, Professor Motiur Rahman, for a great lecture that you have delivered to our audience tonight. As I said, at the peak of our session tonight, we have about 100 over viewers from both the YouTube and also from this Zoom. Okay, now let me introduce for our speaker for the coming session. Okay, all right, he is what we call that, sorry, the speaker is from Indonesia, all right, and he is, wait, I got his slide. Okay, he is Dr. Benny Sugiharto. Okay, he will talk about early orthodontics treatment, myths and facts. So this is Dr. Benny Sugiharto from Indonesia, from University of Indonesia, was taken. Right, so he will speak to us on the 24th of November. So please do join us on this 24th of November from speaker from Indonesia, Dr. Benny Sugiharto. So he's, I understand, a staff of one of the Indonesian university. So with that, I think thank you all of us tonight, the president, the deputy president, and also all the council members who have joined us. And thank you again to our speaker. And hopefully we'll meet again on the 24th of November for our second slot for the month of November. Till then, have a good rest and see you then all in 2 weeks' time. Thank you very much. And good night.
Good night.
Okay, good night.
Good night.
Good night. Thank you, Emmy and
thank you, Professor Ibrahim, Professor Howe, and Professor Asad. Thank you for your time.
Yeah,
I really enjoyed your company. Thank you. Thank you very much.
Yeah.
Thank you.
Like to see face to face in the near future.
Certainly. Can't wait.
Okay. All right.
I'm on the progress. Professor Howe, I'm in the progress for our activity in Bangladesh. I will let you know soon.
Thank you.